The most common goiter worldwide is a lack of iodine in the diet. In the U.S., where the use of iodized salt is common, a goiter is more often due to the over- or underproduction of thyroid hormones or to nodules that develop in the gland itself. You would see a visible swelling at the base of the neck that may be particularly obvious if a man is shaving or a woman is putting on makeup. A tight feeling in the throat, coughing, hoarseness, difficulty swallowing, difficulty breathing. A goiter is associated with an overactive thyroid, and it does usually involve a high level of thyroid hormone in the blood and a lower than normal TSH level. Levothyroxine will resolve the symptoms of hypothyroidism as well as the release of thyroid-stimulating hormone from the pituitary gland, often decreasing the size of the goiter. Aspirin or corticosteroid can be given for inflammation. If the goiter is related to hyperthyroidism, then they may remove part of the thyroid gland. Radioactive iodine was also discussed in endocrine diagnostics. Hashimoto's thyroiditis is a condition where the immune system attacks the thyroid. This is treated with lifelong levothyroxine, and TSH levels are checked every 6 to 12 months. Hyperthyroidism is a metabolic imbalance that causes overproduction of thyroid hormones. The thyroid gland produces thyroxine, T4, and triiodothyronine, T3, responsible for certain metabolic processes like energy metabolism, temperature regulation, and other sympathetic activities in the body. It is the second most prevalent endocrine disorder after diabetes mellitus and affects more women than men. Graves' disease is the most common form of hyperthyroidism caused by the abnormal stimulation of the thyroid gland by circulating immunoglobulins. The diagnostic finding is an elevated T3, T4 level, a high radioactive iodine uptake through thyroid scanning, and this is the most common treatment for Graves' disease, although surgery may be used. Treatment is propylethyluracil, PTU, which blocks the synthesis of thyroid hormones to decrease the output of T3 and T4. PTU and also methimazole have life-threatening adverse effects, and that's agranulocytosis. Sodium iodide lyses the thyroid gland cells to bring the thyroid gland activity down. Saturated solution of potassium iodide, SSKI, is reserved for severe thyroid toxicosis by blocking synthesis of thyroid hormones to decrease the output of T3 and T4. Propranolol, a beta-adrenergic blocker to relieve the signs and symptoms of hyperthyroidism, like hypertension, tremors, tachycardia, irritability, but be sure you take an apical pulse. Medications used to block the synthesis of thyroid hormones may take 2 to 3 months before the full effect is seen. Large doses of iodine are used to inhibit the synthesis of thyroid hormones. Exercise using large muscle groups is encouraged to decrease the irritability and hyperactivity associated with high levels of thyroid hormones. Management would also include thyroidectomy, which is the surgical removal of the thyroid gland. A subtotal thyroidectomy is done to patients with hyperthyroidism, which about 5/6 of the total thyroid tissue is removed. Patients need to be evaluated for hypothyroidism, which can develop after surgery. Lugol solution, potassium iodide, decreases thyroid vascularity, inhibit iodine release. It's diluted in milk or juice because it stains the teeth. They need to use a straw. Radioactive iodine, a tracer is okay to be around the family. There is a high incidence of post-radiation hypothyroidism after radioactive iodine, and a patient needs to be monitored for symptoms of hypothyroidism. Radioactive iodine has a delayed response with the maximum effect not seen for 2 to 3 months, and so the patient should continue to take antithyroid medications during this time. The therapeutic dose of radioactive iodine is low enough that no radiation safety precautions are needed. Nursing management: provide a cool environment. Minimize the stress by providing privacy and placing the patient in the private room if possible. Teach the patient to avoid stimulants like coffee, sweets, tea, soft drinks, energy bars, cigarettes. Watch out for signs of agranulocytosis, which is a decrease in white blood cells, and this would be an onset of a fever and sore throat when patient has medications such as PTU or methimazole. And just monitor for anything unusual such as an allergic reaction to drugs. Patient care post-thyroidectomy. Remember, assessment. Assess the airway. Look for any obstructions due to inflammation. Assess the vital signs. This helps detect bleeding or hemorrhage. Assess the bleeding. Look at the patient's dressing at the back of the neck. Observe if patient always swallows, which could be a sign of bleeding. Monitor for signs of hypocalcemia. Monitor their voice quality. The complication would be airway obstruction, or laryngeal nerve damage. It's normal to have a hoarse voice within the first 3 days to weeks. There's no improvement to the voice for 6 weeks to 12 months, then it could be considered permanent damage. Also assess again complication, hemorrhage, or hypoglycemia. Signs and symptoms to look for: tetany, paresthesia, bronchospasms, Shavastic sign, Trousseau sign, or a prolonged QT interval on cardiac monitor. And at the bedside, make sure you have oxygen, suction machine, tracheostomy set, and calcium gluconate. A thyroid storm is a life-threatening condition in which patients with underlying thyroid dysfunction exhibit exaggerated signs and symptoms of hyperthyroidism. A thyroid storm is brought on by stressors like an infection, diabetic ketoacidosis, surgery, trauma, heart failure, or even a stroke. The condition can result from discontinuation of antithyroid medication or as a result of untreated or inadequate treatment of hyperthyroidism. The excess thyroid hormones increase metabolism and affect the sympathetic nervous system, which increases oxygen consumption and heat production and altering fluid and electrolyte levels. This is going to be sudden onset of fever, tremors, flushing, diaphoresis, tachycardia, dysrhythmias, extreme restlessness, nausea, vomiting, diarrhea. The vital signs could be systolic hypertension or even hypotension. They could be tachycardic, tachypnic, and a temperature of 102 or higher. The patient neurologically can be agitated, delirious, cardiovascular, bounding pulses, systolic murmur, widening pulse, weak thready pulses, pulmonary, crackles could be present, gastrointestinal, increased bowel sounds, thyroid could be enlarged or nodular. And so if you look at a nursing diagnosis, this would be decreased cardiac output related to the increased cardiac work secondary to increased adrenergic activity. So your outcome is you want the patient to be alert and oriented. Make sure their peripheral pulses are palpable, their lungs are clear to auscultation, their urine output is at least 30 mL an hour, and the absence of life-threatening dysrhythmias. Be sure to monitor the ECG for dysrhythmias in the heart rate. A heart rate greater than 140 can adversely affect cardiac output, and monitor for ST segment changes that could indicate myocardial ischemia. Monitoring the oxygen saturation with pulse oximetry. If they have a SWAN, you would monitor pulmonary artery pressure, monitor fluid volume status, urine output hourly, and determine fluid balance every 8 hours. Assess their cardiovascular status. Complaints of orthopnea or dyspnea on exertion. Look at the hydration status because dehydration can further decrease circulating volume and compromise cardiac output even further. Assess for pressure ulcer secondary to hypoperfusion. Be sure to review the thyroid studies. Look at what the serum electrolytes are, serum glucose, serum calcium levels. Review serial ABGs for hypoxemia and acid-base imbalance, which could adversely affect cardiac function. Review serial chest x-rays for cardiac enlargement and pulmonary congestion. Management is administer dextrose-containing IV fluids as ordered to correct glucose deficits. Carefully assess the patient for heart failure or pulmonary edema. Dopamine may be used to support blood pressure. Provide supplemental oxygen as ordered to help meet increased metabolic demand. Once the patient is hemodynamically stable, provide pulmonary hygiene to reduce pulmonary complications. If the patient is in heart failure, typical pharmacological agents for treatment of heart failure may also be indicated. Reduce oxygen demands by decreasing anxiety, reduce fever, decrease pain, and limit visitors if necessary. Eye care for patients with exophthalmos. They may need eye shades or glasses, especially if they're photosensitive. Eye drops to help keep the eyeballs moist. Cover with a clean gauze, especially at bedtime, to promote sleep. And raise the head of the bed to relieve eye swelling. They should have glasses on, especially when outdoors, to protect the corneas. Question and clarify any medication orders for aspirin, because make sure aspirin is avoided as this can increase free thyroid hormones in the system.